Hey everyone, and welcome back for another deep dive. This time we're going to be diving into acute coronary syndrome. You guys sent some really interesting articles for this one.
Yeah, these are great. We've got one on diagnosis, one on all the new treatment stuff coming out, and then one on, get this, influenza and its impact on heart health.
Yeah, that last one really caught my eye too. I mean, it makes sense when you think about it, but it's not something you hear about every day. But hey, that's why we do these deep dives,
That's
right?
right.
To uncover these surprising connections.
Exactly. It's all connected, right?
It really is. So, okay, let's start with the basics. I think most people probably have a general idea of what a heart attack is, but when we talk about acute coronary syndrome, what exactly are we talking about? What's going on in the body?
So, in the simplest terms, it's all about blood flow, or should I say lack of blood flow. We're talking about reduced blood flow to the heart muscle, which obviously is not a good thing.
Definitely not. And just how common is this? Are we talking about a small handful of cases every year, or is it a bigger issue?
Oh, it's a big one. We're talking about a major global health concern. Think over 7 million cases each year worldwide. And here's the thing. A lot of people think acute coronary syndrome and they picture one specific thing, but it's not a one-size-fits-all situation.
Okay, so break that down for us. What are the different ways this can actually show up?
So broadly speaking, we categorize these cases into two main types, STEMI and NST-ACS. They're basically two different ways the heart muscle can be affected. About 30% of cases are STEMI, and that's often what people picture when they think heart attack. That classic crushing chest pain, the Hollywood heart attack.
Drama, clutching the chest, the whole 9 yards. Got it.
Exactly. But here's the catch. The majority of cases, the NST-ACS, might not present with such obvious symptoms. And that's where things get tricky, especially for women and folks with diabetes.
Tricky how so? I mean, isn't chest pain the big red flag?
You'd think so, right? But instead of that classic heart attack presentation, they might experience shortness of breath, fatigue, maybe some discomfort in their jaw or arm, or even what feels like indigestion.
Wow, so easy to brush those off as something else entirely.
Exactly. It can be incredibly difficult to connect the dots. So, bottom line, if you're experiencing anything that seems off, even a little bit, don't hesitate to get checked out.
Better safe than sorry, right? So let's say you go to the doctor because something just doesn't feel right. How do they even begin to figure out if it's actually ACS or something else entirely?
Well, in the outpatient setting, it really becomes a process of elimination because there's no single test that definitively says yes or no. Your doctor will consider your medical history, your family history, any risk factors you might have, like smoking, high cholesterol, diabetes. It all gets factored in.
So it's kind of like a giant puzzle they're trying to piece together.
That's a great way to put it. They use a bunch of different clues to get a sense of what's going on. And there's this tool called the Marburg Heart Score. It's really interesting. It helps assess how likely it is that your symptoms are related to coronary artery disease.
Oh, interesting. So kind of like a credit score, but for your heart. High score. Bad news.
Pretty much. The higher the score, the greater the concern, and the more urgently you'll need further investigation. But even if that initial assessment doesn't scream heart attack, things can escalate quickly, and that's where the ER comes in.
And in the ER, I'm guessing speed is of the essence.
Absolutely. Every minute counts when it comes to potential heart damage.
So let's shift gears then and talk about what happens when you hit those ER doors. You're rushed in, maybe some chest discomfort, maybe not. What are those first few critical steps the ER team takes?
First things first, an ECG. And we're talking immediate.
ECG, that's the electrocardiogram, right?
That's the one. It basically gives us a real-time look at your heart's electrical activity.
So they can actually see what's happening in there beat by beat.
Precisely. And it's especially crucial for identifying a STEMI. Remember, that's the type where a major artery is totally blocked. Early detection is key.
So the ECG is like the frontline intel, giving the doctors a clear picture of the battlefield.
Exactly. Now, here's where it gets interesting. Even a normal ECG doesn't completely rule out ACS, especially in the early stages. Some patients might have a normal reading initially, but their symptoms persist.
So what happens then? What other tools do they use to make sure they're not missing anything?
Alongside the ECG, we'd also do a blood test to check your cardiac troponin levels.
Troponin levels. Okay, now we're getting into some serious medical jargon. Break that down for me.
Think of troponin as a protein that leaks into your blood when heart muscle cells are damaged.
Uh-huh. So it's like a distress signal.
Exactly. And with these high-sensitivity troponin tests that we have now, even the slightest leak won't go unnoticed.
So even if the ECG is given the all clear, the troponin test might be waving a giant red flag.
Precisely. It's all about putting the puzzle pieces together. ECG for real-time electrical activity, and troponin for actual heart muscle damage.
Got it. So those two tests together give the ER team a pretty clear picture of what they're dealing with. So the ER team has all the information from those tests, and let's say it's not good news, they've confirmed it's ACS. What happens next? What can someone expect in those first few critical hours?
Well, that's where the "it depends" comes in. Remember we talked about those different types of ACS STEMI and NST ACS. Treatment is definitely not one size fits all.
Right, makes sense. So let's break it down, starting with the most urgent scenario, the STEMI. What needs to happen and how quickly?
So with the STEMI, we know a major artery is completely blocked. Time is muscle, literally. We need to open that blockage ASAP to restore blood flow. Ideally, we're talking coronary angiography and PCI within 120 minutes of arriving at the hospital.
Okay, whoa, a lot of big words there. Coronary angiography, PCI, for those of us who aren't cardiologists. Walk us through what those are.
Sure. Coronary angiography, it's basically a specialized kind of X-ray. It lets us see very clearly the coronary arteries, like getting a roadmap of your heart's plumbing. And with that roadmap, we can pinpoint exactly where that blockage is, how bad it is, all that.
So you can see the problem area in high definition.
Exactly. And once we know where the issue is, that's where PCI comes in. That stands for percutaneous coronary intervention, but a lot of people know it as angioplasty.
Angioplasty. Okay, I've heard that term before.
Yeah, so basically we thread a catheter, which is like a long, thin tube, up through a blood vessel in your groin or your arm all the way up to your heart. At the tip of that catheter is a tiny balloon. We inflate that balloon right at the blockage site, and that opens up the artery again. And then often we'll put in a stent, which is like a tiny little mesh tube, to help keep that artery propped open and prevent it from closing up again.
Wow, it's like a whole construction project going on, but inside your heart.
Amazing. It really is. Now, all that being said, what if for some reason you can't get to a hospital that can do PCI within that 2-hour window? Say you're in a more remote area. That's where fibrinolytic drugs, or clot busters as they're sometimes called, come in.
So those are like the backup plan.
Exactly. They work by, you guessed it, busting up that blood clot that's causing the blockage. Now, they're not a perfect solution. PCI is still the gold standard for STEMI. But clot busters can buy us precious time to get you transferred to a facility that can perform the procedure.
Makes sense. They stabilize the situation while you get to where you need to be. So that's STEMI, very much a time-sensitive emergency. What about NST-ACS? Is it handled the same way?
Not always as time sensitive, no. With NST-ACS, it's often a partial blockage, or the artery might not be as critical for blood supply. It's still serious, don't get me wrong, but the urgency isn't always as high as with a STEMI.
Okay, so there's a little more breathing room, time to assess the situation carefully.
Exactly. We'd still do a coronary angiography to see what's going on in there, but the next steps might vary. Some folks will need PCI, others might be better candidates for bypass surgery. That's a whole other topic. And sometimes medication alone might be enough to manage the condition effectively.
So it's a much more personalized approach, taking into account the whole picture, right?
Exactly. It's about finding the best treatment for that individual, not just following a one-size-fits-all protocol. But regardless of the specific approach, medications are key. They play a huge role in managing ACS, both in the short term and the long term.
And that's where that dual antiplatelet therapy comes in.
You got it. DAPT, that's what we call it for short. Usually means you'll be on 2 different medications to prevent those platelets from getting sticky and forming clots. Aspirin is one you've probably heard of.
Yeah, aspirin's a common one. What about the other medication?
Could be clopidogrel, prasugrel, ticagrelor. There are options, and your doctor will figure out which is best for you.
So those medications are basically acting like little bouncers in your arteries,
Right.
keeping those clots from causing any trouble.
That's a great way to put it. Now, how long you stay on DAPT, that can really vary. A year is pretty standard, but some folks might need it shorter term, others longer. It all depends on your individual risk factors and the type of ACS you had.
So it's not a set it and forget it kind of thing. Ongoing monitoring is key.
Absolutely. Okay, so we've talked about that initial treatment phase, what happens in the ER, in the cath lab, all that. But recovering from ACS, that's a marathon, not a sprint.
Right. It's about more than just those first few hours or days, right?
Yeah.
It's about making long-term changes.
Exactly. And that's where those 3 pillars of long-term ACS management come in. And just a little spoiler alert, medication is only one piece of the puzzle.
Okay, now you've got me really curious. Lay those pillars on me. What are we talking about here? Okay, spill the tea. What are these 3 pillars? And don't hold back on the details.
All right, pillar number 1, and this one's huge, is quitting smoking. Yeah, I know. Broken record, you've heard it a million times. But seriously, after an ACS event, it's not just about, oh, it's bad for you, it's crucial.
Okay, message received. No more smoking. What about number 2? What's the next pillar?
This one's a bit surprising for some people. Get your flu shot.
Yeah.
Every year.
Hold on, the flu shot. I'm not going to lie, I did not see that one coming. I mean, it's good advice in general, but what's the connection to heart health?
It's pretty wild, actually. Turns out having the flu, like a full-blown influenza infection, it really stresses your body out, and that includes your heart. Research shows it can seriously increase the risk of major cardiac events, especially in those few months after you've had a heart attack. So getting your flu shot, it's like giving your heart a break, a chance to recover and stay strong.
Okay, I'm convinced. Flu shot it is. All right,
Yeah.
bring on pillar number 3. What's the final piece of this heart-healthy puzzle?
Last but definitely not least, we have cardiac rehabilitation. And I know for some people that term can sound a little intimidating, like rehab. What does that even mean? But it's really not about being hooked up to machines all day. It's about getting back on your feet, literally.
So like physical therapy, but for your heart.
Exactly. It's a structured program, usually run by a team of specialists. So you've got nurses, physiotherapists, dietitians, sometimes even psychologists, all working together to tailor a program just for you.
Sounds pretty comprehensive.
It is. You'll do exercise, obviously, but it's all very gradual and tailored to your fitness level. It's not like suddenly you're bench pressing your weight or anything. The goal is to build endurance, learn how to stay active safely, all that good stuff. But there's also a big educational component, like learning about your condition, how to manage it, what to look out for, all those things that empower you to take control of your health.
Knowledge is power, right?
Yeah.
The more you understand, the less scary it all seems.
100%. And I think this is so important, there's the support aspect. You're with other people who get it, who've been through similar experiences. That sense of community, of not being alone, it's huge.
There's something so powerful about that, knowing you're not the only one going through it.
Yeah.
Okay, this is all great info, but I imagine some folks might be thinking, okay, cardiac rehab sounds great, but I can barely get to the grocery store these days, let alone commit to a whole program.
And that's a valid concern. But here's the good news. Cardiac rehab is evolving. These days, there are even home-based programs. You can literally do it from your living room. Your care team keeps tabs on you remotely. You've got videos and online resources, the whole 9 yards. It's making it way more accessible.
That's fantastic. It's amazing to see how healthcare is adapting to meet people where they're at. Well, I have to say, this has been an incredibly informative deep dive. We've covered so much ground from those very first warning signs of ACS to the different ways it's diagnosed and treated, and then all the way to those crucial steps you can take to protect your heart in the long run.
We really covered it all, didn't we? It's amazing how much progress has been made in cardiology, even just in the last few years. But I think the biggest takeaway here is that knowledge is power. The more you know about ACS, the better equipped you are to advocate for yourself, to make informed decisions, and to live a long, heart-healthy life.
I couldn't have said it better myself. And remember, everyone, this is just a starting point. If you have any questions or concerns, always reach out to your doctor. They're your best resource for personalized guidance. And on that note, that's a wrap on this deep dive into acute coronary syndrome. Until next time, stay curious and take care of those tickers.